Randomized controlled trials have become a lot more popular in the media at the moment, given that we're trying vaccines against placebos to see if they affect patients being admitted to hospital and subsequently ICU. And in this video, we're going to take a look at randomized controlled trials and non-randomized controlled trials in a little bit more detail. Randomized controlled trials are considered really high on the hierarchy of evidence, just below systematic and meta-analysis. But remember, it's only a good trial if the methodology is good. And you can have those confounding variables, problems with randomization, or problems with statistical analysis that render the RCT below a cohort or even a case control study. The second part of this video is by the Cochrane Collaboration, and it's actually a video of a person going through each step of the CASP critical appraisal tool, which you may have already done in this module. If you've got an RCT for your assignment, the second part of this video would be really good to watch, to actually see that CASP tool used against a randomized controlled trial and how to integrate that into your assignment. The key to understanding randomized controlled trials is really in the first two words, randomized and controlled. Firstly, within a randomized controlled trial, patients are allocated randomly to groups, and that's often done by a computer system or number algorithm that enables patients, no matter who they are or the demographical background, is assigned to a group without the researchers knowing. Sometimes in trials, you would ideally want two groups, one who receives an intervention and one who doesn't. Remembering back, that's one who receives a manipulated independent variable and one who doesn't. And we're looking to see if these act on the dependent variable. Sometimes in randomized controlled trials, you can actually have 2, 3, 4, 5, or 6 groups. The key at looking at these is to be sure that they are randomized. And that's often said within the methodology of papers of how they've done that. The second thing is control. We want to control as many of those confounding variables as possible, and ideally reduce those and have control over the independent variables. And those are the things that we're trying to do in an RCT. But of course, as we've learned, there will be confounding variables that do try to act on the dependent variable. Within a randomized controlled trial, both groups are followed up for a specific amount of time and should be followed up for the same amount of time, and this is agreed within the study protocol. Often when looking at an RCT, you'll find that there's words like blind or blinded, and this relates to who actually knows what's going on in the trial. First of all, you have a blind RCT. And what this will mean is that the participants, those that are receiving injection, won't know if they're getting the real one or getting the placebo. And this was done in a lot of the COVID trials as well, that participants would receive a vaccine and not know if they'd received it or received a placebo. The reason for this is that receiving either and knowing about it could have psychological implications, and patients could actually think that they're developing symptoms when really they're not. The second one is double blinding, and what that means is both the participant and the researcher is not aware. Again, this was done in a lot of the COVID randomized controlled trials, in that patients didn't know if they were getting the vaccine, and likewise the researchers didn't know if they were giving them the vaccine or giving them a placebo. The idea is to reduce those confounding variables and the biases. What we're trying to do in randomized controlled trials is also that outcomes are defined from the start, and what we're trying to decide is what we're going to look at. This may be death rates, heart attacks, or improvements, and you'll see a lot of the randomized controlled trials within the title or within the research methodology will state what aspects they're looking at. The idea is to control those independent variables, and the dependent variables here would be the death, the heart attack, or the improvements. So we're trying to really control the trial as much as possible. So although that randomized controlled trials are placed really high up there on the hierarchy of evidence, there are some disadvantages to them. And the first obvious one is that when you're dealing with lots of patients, randomizing, statistical analysis, and also deciding if researchers are blind or not, and following patients up for a long time, they are really, really expensive to do. And this is the predominant reason why some people don't opt to do a randomized controlled trial, is based on funding. Because they're really expensive, you often get other people involved in the research. Typically in drug trials, these are large drug companies that haven't invested a lot of money into their drug and therefore ideally want to see it work. You can also get other things like equipment manufacturers, for example, in some randomized controlled trials in paramedic science, looking at compressions relating to Lucas, automatic compression machines. These are often funded by the manufacturers as well. And those can introduce biases because they also have a key stake within the research. So if you've got an RCT that's funded or partially funded, make sure that you have your skeptical hat on and try to look for some of those biases that could potentially be there. They're really, really time consuming as well. And you'll get a lot of trials that are undertaken on too few patients for a too short a time period. And obviously, the more time period that you look at, the more money it costs. So we have to be really, really careful when looking at RCTs to make sure that their sample size is enough. Ideally, that they've got a power calculation as well that John has gone through, and also that the follow-up time that they're looking at these patients is appropriate and not ending the time early. For example, in a drug trial where you're ending it early and you haven't seen the full range of side effects from a vaccine or from a drug that's going to be given. They're also introduced to hidden biases from those confounding variables as well. And it's quite common to see that there's randomization problems with patients. And what you may have is a randomized controlled trial where randomization has not been occurred by a computer algorithm or a numerical algorithm. And this can create biases as well, that sometimes researchers do the randomization themselves and it's not true randomization. You can have selective participation as well in the sampling, where you maybe only actually sample a set group of patients, for example, based on age or demographics or comorbidities. And what this is doing is reducing the overall generalizability of the sample to other people. You may also get blinding not completed, and this can be on the side of the participants, but also the researchers as well. So the best randomized controlled trials are those that are double blinded. Remember that the participants don't know what's happening with the intervention, and also the researchers don't know as well, and that's reducing the bias. There's also ethical considerations as well. And what that means is that we have to be aware of what we're ethically doing. For example, if we're only going to give a set of patients one drug, what could the potential effect be on those patients who aren't going to get it or going to get the placebo? This is sometimes really hard to do when you're looking at a study that's relating to the quality of care. So for example, if we were going to only give some patients antibiotics or only going to give some patients a medication, what are the ethical considerations for that standard of care for the group not being investigated? And it's really key to have a look at the studies that you're examining to see if they've had ethical approval from an external organization or ethics committee. And finally, what you'll get is a lot of things are actually conducted that don't need to be done. And you'll probably see multiple randomized controlled trials done for the same thing. What we need to be aware in the research process is, do we need to do the research in the first place? Is there a more recent randomized controlled trial? Or better yet, is there a systematic review of multiple trials, which is going to give us a better result rather than starting off the randomized controlled trial chain again? As I said previously, the second part of this video is by the Cochrane Collaboration, and they're actually looking at a randomized controlled trial and along that completing the CASP critical appraisal tool. If you've got a randomized controlled trial, it's really worth watching this video to see how they apply that tool to a randomized controlled trial. And also, if you want to learn more about randomized controlled trials in general, I definitely suggest watching the last part of this video.
Welcome to the third video in this series of critical appraisal modules. In this module, we'll be focusing on the critical appraisal of randomized controlled trials, or RCTs, using the Critical Appraisal Skills Programme, or CASP approach. By way of learning outcomes for this session, we aim to demonstrate to you the key principles and stages of RCTs so you will know broadly how they are conducted and when we might want to refer to this type of evidence in decision making. We will be referring to an open access published RCT, and by using the CASP checklist, we will walk through the checklist items and perform a critical appraisal to help demonstrate what we need to be looking out for when appraising this type of research for ourselves. Both links to the RCT and the CASP checklist are below this video. Finally, there will be a link to a short quiz at the end of this video, which will give you the opportunity to test your knowledge on concepts we will have discussed using multiple choice questions and answers. We will be making reference to a recent BMJ Open published RCT entitled Marita Therapy for Depression, a Pilot Randomized Controlled Trial conducted by Sugg et al. Randomized controlled trials are considered to be the gold standard of evidence because, when conducted well, they are methodologically robust and able to establish a cause and effect relationship between an exposure and an outcome. In an RCT, a number of similar people are randomly assigned to 2 or sometimes more groups to test a specific drug treatment or another intervention. One group, the experimental group, has the intervention being tested. The other, the comparison or control group, has an alternative intervention, which may include a dummy intervention, placebo, or no intervention at all. The groups are followed up to see how effective the experimental intervention was. Outcomes are measured at specific times, and any difference in response between the groups is assessed statistically. RCTs are considered a gold standard of evidence precisely because they aim to reduce bias and control for confounding variables when searching for estimated magnitude of effect of an intervention. They also control for participant selection bias by the act of randomizing participants to either intervention or control group, that is, without any arbitrary preference by the researchers or clinicians if they could guess whether a participant is likely to benefit from one treatment over another. Such arbitrary allocation could result in overestimating any effect of the treatment. The act of randomizing individuals to one treatment or another, which is analogous to a coin toss, permits the use of probability theory to express the likelihood that any difference in treatment outcome between groups merely indicates chance. However, randomization needs to be done well if it is to be truly random. For example, randomizing people by their surname or year of birth is not a truly random approach. This is because participants with the same surname or year of birth can certainly share similar characteristics. Randomization can be done in the following ways. Simple randomization, in which there is no restriction on allocation and groups could be unequally sized. Block randomization, in which allocation is performed in blocks so that groups are equally sized within each block. Or stratified randomization, in which factors such as age or sex are randomized separately so that they are equally distributed amongst the groups. There are statistical methods available to help researchers randomize participants in a reliable way. Computer-generated random numbers are usually used to generate the group that a patient goes into. RCTs are also able to produce stronger evidence by protecting against detection bias through the act of double-blinding both researcher and the participants. That is, neither participant nor researcher knows which intervention they are receiving or administering respectively. By blinding both parties, behaviour and subjective beliefs about whether the treatment is working or not are less likely to influence the objective outcomes of the research. Single blinding may also be used in an RCT, in which only one party is blind to treatment allocation, be this either researchers or participants. This form of blinding may still introduce bias if, for example, only the participants are blind to treatment and the researcher, knowing treatment and allocation, may have an expectation of what the outcome should be and subsequently, consciously or subconsciously, influence the administration of the interventions or the behaviour of the participants. However, it is clear that sometimes double-blinding to treatment is not always possible or ethical, particularly if the intervention under investigation is not a drug, which can be more easily blinded and allocated by using a replica inert pill or a placebo. In cases in which blinding is not possible, the outcome measures should ideally be objective, because knowledge of group assignment may well consciously or subconsciously influence any subjective measures, for example, subjective pain measures. Qualitative or observational research, usually non-randomized and non-blinded studies, in testing interventions are typically unable to adequately control for selection, allocation and detection bias than randomized controlled trials. This is not to say that RCTs are immune from these various types of bias, but greater care is taken over control of the research environment in order to isolate cause and effect with greater certainty. The main criticism of the applicability of randomized controlled trials generally is their external validity. That is, the applicability of the results of the research outside of the controlled research environment. From the critical appraisal concepts we've learnt, we know that internal validity, relates to the validity of the conclusions within a study context. In contrast, external validity relates to the validity of applying the conclusions outside of the context of the trial. External validity is affected by many factors, notably the healthcare system in which the RCT is undertaken, country and culture, selection of participating centres and clinicians, and participant eligibility criteria. As such, this can affect the extent to which the results of a trial can be generalised to and across other situations, people, and time. Other limitations of RCTs include their high cost, since they can typically take rigorous planning, preparation, and consume a lot of time in their undertaking and analysis. RCTs can also be logistically challenging in terms of organising and supervising potentially multiple study sites and locations. We'll now be taking a look at the critical appraisal concepts of validity, trustworthiness of results, and value and relevance alongside the RCT CASP checklist and the RCT publication by Sugg et al. The first question on the checklist asks us to consider whether the review authors have been explicit and clear in their inclusion criteria relating to the population or participants of interest, the intervention given and comparator or control condition, and the outcomes considered. As we saw in the previous module on systematic reviews, we can identify that this is a PICO consideration. Because the trial authors also published a protocol and direct the reader to it in describing their methods, this provides a level of confidence that their methods have been carefully developed and peer-reviewed, and it also enhances the transparency of their research and reduces the risk of selective reporting bias, because we can see that they have not altered their choice of outcomes. In the RCT, we can see that participants were defined as being 18 years old or above with a DSM-4 major depressive disorder diagnosis, with or without DSM-4 anxiety disorders. In defining the intervention and comparison groups, the authors make effort to contextualise the current state of evidence in the area of meritotherapy. They highlight that it is a form of psychotherapy developed in Japan in 1919, informed by Zen Buddhist principles. It teaches patients to live with rather than be without their symptoms. They also distinguish the therapy from other similar acceptance and commitment therapies by describing the importance of reorienting patients in the natural world and potentiate the natural healing capacity through the therapy. The control group was treatment as usual on its own, which included a waiting list or no intervention. The authors state their outcomes of interest for the RCT being self-report data at baseline and at 4 months treatment, including severity of depressive symptoms using the PHQ-9 scale, severity of generalised anxiety disorder symptoms using the GAD-7 scale, quality of life, and work and social adjustment outcomes. Participant attitudes were also measured using a meritotherapy-specific questionnaire. This question relates to how randomisation was carried out and whether the allocation sequence was concealed from researchers and the participants. Sugg et al. State that the RCT undertaken was a pilot feasibility trial, which are generally smaller in participant number and are conducted to consider the patient acceptability and the logistics of carrying out a larger trial in the future. The authors used a parallel group randomised controlled design using a 1-to-1 ratio using a computer-generated random allocation sequence at the Exeter University Clinical Trials Unit. And in order to ensure allocation concealment, they used an externally administered password-protected randomisation website developed and maintained by the same CTU. The third question relates to the issue of whether all participants who were originally randomised to a treatment group were subsequently analysed in the same treatment group to which they were assigned. Participants can drop out of studies for various reasons or be lost to follow-up. Participants may also, however, not respond well to the intervention to which they were assigned, and so may be removed from a trial for non-acceptability. We will want to see how RCT authors managed their study and what protocols they established in the event of losing participants at follow-up, and how they would include their data in the final study results in order to reduce the risk of attrition bias of the research. The authors of Sugg et al. State that out of a total of 68 participants randomised, which were 34 to each group, 67 of those were analysed. One participant in the treatment as usual group withdrew consent completely, and so were removed entirely from the collected data and results. There were, however, additional dropouts, including one in the Marita therapy and 3 more in the treatment as usual group. Reasons were provided for these losses, and the authors undertook statistical analysis on an intention-to-treat basis, and did not impute any missing data. Intention-to-treat analysis adheres to the rule, once randomised, always analysed, in order to ensure that no participant data is unfairly excluded. ITT is generally considered a less biased way of reporting outcome data, because participants' final results are included at the point at which they left the trial. The authors seemingly adhered to this principle and reported outcome data for all the participants, minus the one who withdrew their consent. The fourth question asks us to consider how blinding was carried out by the RCT authors. As we discussed, blinding can help reduce performance bias. This refers to systematic differences between groups in the care that is provided or in exposure to factors other than the intervention of interest. i.e., participants could change their responses to questionnaires or change their behaviour if they are aware of which group they have been allocated to. We can see that Sugg et al. Did not blind participants nor clinicians to group allocation due to the nature of the intervention. That is, because it would not be possible to blind. The intervention group would know that they were receiving Marita therapy because they are receiving it, and the same for the treatment as usual group, who would be sitting on a waiting list. The researchers could, however, have blinded themselves to group allocation. However, they stated that they could not due to resource limitations. This could be a concern for bias in this RCT, particularly because all outcomes of interest were self-reported. As we saw earlier, in cases in which blinding is not possible, the outcome measures should ideally be objective, because knowledge of group assignment could consciously or subconsciously influence those subjective measures. Because this is a pilot feasibility trial, however, the authors do state that future research would ensure that study researchers would be blinded in future larger-scale trials. Therefore, these limitations would need to be reconciled with the reality of the constraints imposed by a pilot randomized controlled trial. Question 5 asks us to look at whether the participant groups were similar or equal at the start of the trial, including by factors that might affect the outcome. In order to reduce selection bias, it is important that groups are similar and representative samples of the population under study, and that other characteristics, such as sex or age, are less likely to influence outcomes. The authors of this trial used a parallel group randomized control design, and further stratified their sample according to depression symptom severity. We can see in their participant baseline characteristics table that other factors, including mean age and gender, was fairly equal between the two groups. It does seem, however, that more participants with anxiety and secondary disorders were included in the control group. The authors have not addressed this. However, it was specified in their inclusion criteria that participants would be included whether or not they have anxiety disorders, as well as a diagnosis of major depressive disorder. It is not clear how this may or may not have influenced the trial's outcomes. Question 6. Were both the intervention and comparator groups treated equally in terms of other treatments and frequency of follow-up? All participants, irrespective of their allocation, were free to choose whether or not to take antidepressant medication whilst receiving either the Marita intervention or treatment as usual control. Additionally, authors state that all research measures were applied equally between the groups. Participants were all recruited through the same means via record searches at 8 GP practices in Exeter, Devon. However, because there was no blinding of study personnel, we are not able to guarantee, based on the publication alone, whether or not participants were treated equally. We would need to make a judgment as to whether the results of a study can be trusted, or whether biases have ended up invalidating a study. Question 7 asks us to consider what outcomes were measured, whether the primary outcomes were clearly specified, and what were the results for each outcome. The authors reported all stated outcomes, which were from self-reported rating scales. They also dichotomized data for recovery and response outcomes by calculating how many participants from each group had recovered by scoring less on the PHQ-9 questionnaire or responded by showing a 50% reduction in score on the GAD-7 questionnaire. Results showed that more participants in the maritotherapy arm both recovered and responded, as compared to the treatment as usual group. We could argue that this is not surprising, seeing as the treatment as usual group predominantly were on a waiting list. Because this is a pilot trial, the sample size was also small. However, the authors clearly state that the purpose of the trial was to demonstrate feasibility for a future larger scale trial, and to better determine an adequate sample size that would enable significance testing, whilst also allowing for attrition. Question 8 asks us to consider how precise was the estimate of treatment effect. We can make an assessment of how precise results are by taking a look at the confidence intervals. For the primary outcome of severity of depressive symptoms, using a self-reported symptom scale, the authors report the mean difference between the group scores at 4 months of -5.5, with a 95% confidence interval of -8.1 to -2.9. To recap from the previous module on systematic reviews, the narrower the confidence interval around the estimate of effect, the more confident we can be in the result. The present confidence interval is relatively wide. However, it clearly favours the intervention, with the authors concluding that around 68% of people recovered, based on scoring lower on the self-reported scale in the intervention group, with only 30% recovered in the treatment as usual group. Again, the authors do not exaggerate nor claim significance in their results. However, they conclude that these results are from a pilot feasibility study, and therefore the results instead show promise in treating depression, as opposed to definitive answers as to treatment effect of maritotherapy. Question 9 takes us back to the PICO, as well as the other criteria we explored in refining inclusion criteria. When was the trial undertaken? Has too much time passed, rendering the results irrelevant, for example, if a treatment was included that isn't used anymore? Geography. Where was the RCT undertaken? Is the treatment culture different or similar to what you would expect in your local practice? Are participants included in the trial sufficiently similar to your own population of interest? Again, referring back to the PICO will help you make this decision. Sugg et al. State that their RCT on maritotherapy is the first for treatment in depression within English-speaking countries, and that existing evidence up to now has relied on case control studies, largely conducted in Japan. The authors are explicit that it is a treatment not overly familiar in the UK context, but that it may prove to be a valuable addition to current treatment options in a UK context. The authors state that further evidence is needed in this area, which is true, particularly based on the small sample sizes, lack of blinding, and full reliance on self-reported measures, which introduces bias into any finding from this initial pilot trial. Question 10 asks us to consider whether all clinically important outcomes were considered. How have the authors defined their outcomes, and would you consider them relevant in this healthcare area? Or are there outcomes missing that you would have otherwise expected to see? Again, it is important to consider whether outcomes important to healthcare practitioners, commissioners, patients, and caregivers alike have been equal and balanced in consideration. Sugg et al. Describe their efforts in patient and public involvement when developing the protocol to their pilot RCT. PPI is a factor that can help ensure that research takes into account outcomes and practical benefits for patients in the real world, as opposed to relying on researchers and clinicians to define outcomes alone. This final question is, again, really up to you, to make a judgment as to whether you think the benefits of the intervention are worth the harm and the costs. What would you think, based on a critical reading of the evidence and the conclusions drawn from this RCT? The fourth module in this series will look at cohort studies,